Right. Okay. Jane, thank you very much indeed for the introduction, and also thank you to Spain for inviting to this meeting. As you guys know, I love coming to Spain and also the Life Rep group meetings. I love the interaction between ourselves and the patients and the patient advocates. And it's a shame that we can't meet face to face. And I'm sincerely hoping that next year will be a face to face meeting, not Zoom. Not that I'm not against Zoom, but I prefer face-to-face interactions rather than the computer interactions. So what we're going to talk about in the next 40 minutes is where we are now with the non-KIT, non-PDGFR mutated GIST, and also some insights into the biology and what we in Cambridge are doing research-wise and how it has implications to other researchers, and Ruth will be talking about that. And I'll give you a brief summary of what treatments are available for non-KIT, non-PDGFR patients and where we want to go in the future. There will be a lot of time for discussion because though we got a fairly large number of slides, I think we're going to make sure that we will leave enough time for discussion at the end. I want to share my slides now. Let me just see. Exit full screen. Let's give me 1 minute. Speakers view. That's speakers view, gallery view. Okay. Now, can you see my screen?
Not yet, Ramesh.
Screen now?
No.
Share, it's coming in a minute.
There we go. There we go.
Yeah.
Perfect. So it should be, the slide should be starting in a minute now. There you go. So just as an introduction, we just need to remember where we were about 20 years ago. And we should always thank the Japanese group led by Seiichi Hirota for discovering the gain of function mutation in the KIT gene. Without Seiichi Hirota's work in 1998, we wouldn't be sitting here talking about non-KIT GISTs. And also we have to remember Heikki Hunsu when he treated the first GIST patient in 2001. And that was one of the rare occasions where the New England Journal of Medicine actually published a case report. And again, without that patient responding to imatinib, we wouldn't be here talking about what we are doing today. And then we had the second line and the third line drugs and the more drugs coming through. And what we know so far is that there are two major genes involved, KIT and PDGFR, which are located on the chromosome 4. And by default, these mutations, these genes are mutually exclusive. People have not found as yet where the two genes are actually in the same tumor. 15% of the GIST have no activating mutations in the KIT and PDGFR, as you can see in the picture there. We have got stuck with this term called wild type. What it just means is that there are no activating mutations in these two genes. For a start, I don't like the term wild type, and also I don't like to describe something as non-something, but for the time being, at least now in 2020, we still kind of are using these two, wild type and non-KIT GISTs. So we temporarily, I think we'll park this thing to one side and just use the term wild type. Personally, I feel that we should back off from using the term wild type. One of the reasons is that using that wild type, putting all the types of GIST in one basket may actually slow down the research and also an understanding of the biology of the disease. Because we now understand and we now acknowledge the heterogeneity of these tumors. And also I think we come a far way from 10 years ago, and we can define the individual subtypes of wild type GIST now, and there are more to learn. And identifying the oncogenic drivers is a very key element to work out the tailored treatments based on the biology. So this is the kind of a paradigm for personalized medicine, which we already know we doing in the KIT mutated GIST and the PDGFR mutated GIST. And also, I also wear a lung cancer hat. I treat patients with lung cancer, and I've learned a lot there that there are about 20 different types of lung cancers now, what used to be just 2 types. So the understanding of the biology is very, very important to the development of the new treatments. So what used to be non-PDGFR mutant GIST, now we got 2 new GIST which have been diagnosed in the last few years, BRAF mutant GIST. So BRAF mutation is an oncogenic mutation, and the driver kinase is druggable, and we got BRAF kinase inhibitors available now, and the best examples are actually from the melanoma field, and we got BRAF and MEK inhibitors which are highly successful and changed the natural history of melanoma, and we expect that something similar would be the case in patients with BRAF mutant GIST. They're extremely rare. Part of the reason is that we have not been testing them, but we look back at our database, less than 1% of our GIST are BRAF mutant. NTRK, NTRK, we haven't been routinely testing, but so far we have not found one. We tested about 24 so far, and we haven't got a NTRK GIST as yet. So as we know, there are other pathways and other drivers are yet to be discovered, and FGFR comes up quite often, and this could be potentially another pathway which is potentially druggable. Then we have 2 distinct subgroups of the wild type GIST. One is the succinate dehydrogenase deficient GIST, which is a very, very fascinating and very, very challenging GIST. And there are lots of opportunities there to do research and find out the treatments as well. The second one is the GIST associated with the neurofibromatosis 1 syndrome. This is a very, very difficult GIST to treat, and right now there's no standard of care, but again, opportunity for us to do research and develop new drugs. Couple of terms I would like to highlight to you guys, which have come up in the last number of years, 4 or 5 years. The Italians have coined this term quadruple negative GIST. What it essentially means is that no mutations in KIT, PDGFR alpha, and the BRAF is wild type, and SDH is preserved. And then quintuple negative GIST, and that means again we talk NTRK fusion as well, but this again is a descriptive term and doesn't tell you what is driving the GIST. So these are useful terms in one way, that to identify or exclude other types of GIST, but doesn't tell you what is driving the tumor. So that's where we are with the GIST, and what I would like to do is hand over the microphone to Ruth Casey, who will take you through the different subtypes of GIST, their biology, and the genomics of these GIST. And this is for you, Ruth.
Hi. So I would like to begin by firstly thanking Jane for the very kind introduction, and also thanking the organising committee for this invitation. I know you can't see me now because we're sharing the slides, but I'll hopefully see you all at the end when we take the questions. Okay, so Ramesh has just told us that wild type GISTs are quite heterogeneous. There's lots of different drivers. So to try and simplify things, how do we first start to classify wild type GIST, or non-KIT and non-platelet derived growth factor alpha mutant GIST? Well, we believe, it's our opinion, it's also the opinion of some of the other large clinics, such as the NIH clinic, that the next step should be to determine if the wild type GIST has a functioning succinate dehydrogenase enzyme or not, or so-called SDH deficient or SDH preserved GIST. So what is the succinate dehydrogenase enzyme? Well, the SDH enzyme is an enzyme that functions in the citric acid cycle in the mitochondria of our cells, and one of its main functions is to convert the metabolite succinate to fumarate. And the enzyme is composed of 4 proteins, as you can see here, SDH A, B, C, and D, and each of these 4 proteins are encoded by their namesake gene, i.e. the SDH-A gene, B gene, C, and D gene. So a mutation in any one of the 4 genes will mean that the protein doesn't work, and therefore that the enzyme doesn't work. So how do we test for whether the succinate dehydrogenase enzyme is functioning or not functioning in the GIST tumors? Well, in clinical practice, what we tend to use most commonly is immunohistochemistry, and that basically involves using an antibody to detect the presence of a protein. So if the protein is damaged or deleted because of a gene mutation, for example, it won't be expressed or detected by the antibody. And for tumors where we suspect STH deficiency, such as GIST, we use an antibody directed against the STHB protein. That's because the STHB protein is at the core of the enzyme, so mutation in any one of the 4 genes or 4 proteins will mean that the central protein, i.e. the STHB protein, won't be expressed. So we can use that to help us identify any GIST which is STH deficient. So you can see here a GIST which is STH proficient, so the antibody has been applied and the STHB protein stains positive. So this is an STHB preserved or proficient GIST. You compare it to this sample over here, which is an STH deficient GIST, and you can clearly see that the STHB protein here is not staining. So this is the most common tool that we use in clinical practice to quickly tell us whether a wild-type GIST is STH preserved or STH deficient. So what else could we do? Well, we could look for the accumulation of the metabolite succinate, because you'll recall that I mentioned that the main function of the succinate dehydrogenase enzyme is to convert succinate to fumarate. So if this enzyme doesn't work, then you're going to get an accumulation of succinate because it's no longer being converted to fumarate by a faulty STH enzyme. So this is an example of where we have measured metabolites, including succinate, in tumors which have been excised from patients or removed from patients. So the top 3 here are all STH preserved tumors, and the bottom 2 are STH deficient tumors. And here you can see that we clearly see succinate accumulation in the STH deficient tumors. So we can also use accumulation of succinate to detect STH deficiency. But what about patients who haven't had their tumors removed? Well, a couple of years ago, we started to look at a method to look at tumors that are still in the body, or what we would call scientifically in vivo, and look to determine whether we can detect succinate accumulation in these tumors in vivo. And to do that, we use conventional MRI, but the MRI scanner has a special coil built into it, and that coil enables us to acquire a spectrum of metabolites from the tumor that we're particularly interested in. And that metabolite profile that's acquired by this coil is then analyzed using specific software packages, and we can then determine whether there's succinate accumulation or not in the tumors. And of course, the ability to detect succinate accumulation in tumors on scans will enable us, or should enable us, to diagnose STH deficient GIST or STH deficient tumors very early. And it could also be used to follow response to various treatments, where we would expect the amount of succinate to decrease if the treatments are effective. So this is what it looks like when we do it in patients or in clinical practice. So both of these patients had wild-type GIST. We did MRI spectroscopy in both of these patients, and we positioned the coil over the tumors highlighted by the 2 white arrows. So in this case, it was this tumor, and in the case below, it was this tumor. And then we get this metabolite profile. But what's important to note is that in a tumor or a cell that has a functioning succinate dehydrogenase enzyme, we shouldn't expect to see any succinate. But in both of these patients, we can clearly see quite a significant succinate peak, and both of these patients had STH deficient wild-type GIST. So this is just an example of how we can use this technology to detect STH deficient tumors. Okay, so we've mentioned that the first step should be to determine whether the wild-type GIST is STH deficient or STH preserved. But what causes STH deficient GISTs? The most common cause by far are germline mutations in the genes I mentioned that encode the proteins. So germline mutations in STH A, B, C, and D. And a germline mutation basically means a mutation that we can inherit from our parents and we can pass on to our children. In GIST, the next most common cause for an STH deficiency or an ineffective STH enzyme is something called an STHC epimutation. And probably the patients will be most familiar with this being associated with what's called Carney's triad. But what does an STHC epimutation mean? Well, basically it means that there's no problem in the DNA code itself, but the expression of the gene is affected by hypermethylation or too much methylation. And I'll explain that a little bit more as we go on. Very rarely in STH deficient GIST, we see a DNA or a coding problem in one of the STH genes, which is unique to the tumor, but which is not hereditary, i.e. it can't be passed on. What are the causes then of STH preserved or STH proficient GIST? Well, Ramesh has already mentioned, but one of the most common syndromic causes of STH preserved GIST is neurofibromatosis caused by hereditary mutations in the NF1 gene. And then, as Ramesh has said at the beginning, the other causes for STH preserved GIST are predominantly mutations in genes which are unique to the tumor. Again, these are mutations that can't be passed on, or at least we suspect at this point that they can't be passed on. These include mutations in individual genes or fusion gene mutations, as we've heard about. So for the majority of my talk, I'm going to focus on the syndromic causes of wild-type GIST. Okay, so if we focus first on the hereditary or germline succinate dehydrogenase gene mutations. So actually the most common tumor associated with these gene mutations are pheochromocytomas or paragangliomas, and these are adrenaline secretion tumors which can arise either from the adrenal gland or from sympathetic and parasympathetic nerve fibers, which lie anywhere really from the base of our skull to our pelvis. But as we know, the next most common tumor associated with germline STH mutations are GIST. And there are also rare tumors associated with these gene mutations, including renal cell carcinoma and rarely pituitary tumors. And the pituitary is a gland which regulates hormones, and it sits in our brain. And over the past 20 years since these genes were first discovered, we've started to see a pattern in terms of the, in terms of the specific succinate dehydrogenase gene mutation and the development of particular tumor types. So for example, the STHA gene mutation we know is the gene most commonly associated with GIST, whereas the STHB gene mutation is much more commonly associated with pheochromocytomas and paragangliomas and renal cell carcinoma. Okay, so penetrance of tumors and STH mutation carriers, what does that mean? So basically, this means how likely it is that you will develop a tumor if you carry a fault in one of these genes. So if you carry a fault in the succinate dehydrogenase genes, how likely are you to develop a tumor? And actually, we've now come to understand over the past, 3 to 5 years that the penetrance is actually quite low. So that means you're far more likely to never develop a problem if you carry a fault in this gene than you are to develop a problem. And this probably is in line with what patients will know and what we know in our clinics, and that we can have families where multiple family members will test positive for the gene, but very few family members will actually develop a problem or a tumor from the gene. And if we look at STHA in particular, which as I mentioned is the succinate dehydrogenase gene most commonly associated with GIST, we see the penetrance is actually very low, and we suspect it's probably around 2%. So this is important to bear in mind when we counsel families about the risks of developing tumors when we test family members to see if they carry the gene. But it's also important for us as doctors as we try to formulate a plan for screening patients for the development of these tumors that are associated with these gene mutations. So what about in children? How likely is it for children to develop these tumors, and when should we start screening the children of parents who carry a succinate dehydrogenase gene mutation? Well, a few years ago we looked at this, and reassuringly what we found was that the risk of developing a tumor before the age of 5 is very low and essentially 0%. By age 10 it approaches 2% for the succinate dehydrogenase B gene mutation, but remains very low for the other genes. And by the age of 18 the penetrance is approximately 2 to 10%, again varying depending on the individual gene. Of note, when we talked about penetrance in the children, we had to look at the most common tumor, which was pheochromocytomas and paragangliomas. So we didn't actually look at the penetrance of GIST in this group of patients, because this is a less common tumor associated with these gene mutations. So how should we screen patients then who are found to have a germline mutation in one of the succinate dehydrogenase genes? And whether these are patients who might present with the GIST, so how should we screen them for the development of other tumor types? And what about their family members who are found to carry a gene? How should they be screened? Well, again, the screening will vary depending on the specific gene. So for STHB, if the patient is already having screening or imaging performed because of their GIST, it's important to remember to make sure to screen for the other tumours, including pheochromocytomas and paragangliomas. So that should involve a scan of the neck and the chest to screen for paragangliomas there, at least at presentation or a diagnosis of the gene mutation, and if normal, every 3 years. For STHD, important to note that this gene is particularly unique. So all of the succinate dehydrogenase genes are inherited in an autosomal dominant fashion. And what that basically means is that each child of a parent who has one of these gene mutations has a 50% risk of inheriting the gene. For STHD, though, it's a little bit different. You can inherit the gene, but your risk of developing a tumor is dependent on you inheriting the faulty gene from your father. So if you inherit the faulty gene from your mother, the risk of developing a tumor is very, very low, such that we only recommend clinically screening patients for the development of tumors if they inherit the fault in STHD from their father. So you can see for screening for STHD, CNA, again, similarly, we would recommend that the patients have screening for the development of paragangliomas, which would include screening of their neck and chest at least every 3 years. And for A, because it's slightly lower penetrance, as I've mentioned, that screening frequency can be extended out to 5 years. So what about testing the children then? So as I've previously mentioned, the risk of developing tumors is quite low at a young age. So for that reason, we recommend that for children of parents who have an STHB gene mutation, the children are screened for the presence of the gene mutation at the age of 5 years, and that they are then, if they carry the gene, that they're then followed in a clinic with blood tests and yearly clinical evaluation from the age of 5. And because it's not easy to do MRI scans or any imaging tests on young kids, and because of the penetrance that I've just shown you being very low up to the age of 10, we don't recommend doing any imaging on these kids until the age of 10 years. For stage A, C, and D, because the risks were slightly lower in children than for B, we recommend that genetic testing is performed at the age of 10, that the kids are seen in clinic from the age of 10, and that they have their first scan from the age of 15 years. Okay, so moving on from the germline gene mutations then to this epi mutation that I've mentioned. So I mentioned that it's not a problem with the DNA code itself, but a problem with methylation. So just to briefly explain this, so the expression of a gene can be affected by too much methylation in a specific part of the gene, namely the promoter region of the gene. So normally the promoter region of the gene should be kept free from methylation, but if this part of the gene becomes methylated, the gene can be, expression of that gene can be affected. And that's what we see with STHC in patients with GIST in particular. There's too much methylation in this region of the gene, and as a result, the expression of the gene is affected and the enzyme no longer works. And as I mentioned, this particular abnormality is associated with what we call Carney's triad, and patients are at risk of developing GIST, paragangliomas, and also these benign pulmonary tumors called pulmonary chondromas. We've looked at the rates of STHC epimutations in our clinical practice in the post-GIST clinic, and we found 6 patients who have an STHC epimutation. All the patients were female. Unfortunately, all of the patients had metastatic disease. They were much younger at diagnosis than or patients with STH deficient tumors caused by germline gene mutations, and also they were more likely to have multiple tumors, i.e. developing the other tumors I've mentioned as part of Carney's triad, such as paragangliomas and pulmonary chondromas. And one of the things we're frequently asked in our clinical practice is whether this STHC epimutation can be inherited. So is this something that one can pass on to their children, or something that we would need to worry about for the siblings or the parents of the patient? And we looked at this again a couple of years ago, and we've published this work. And to try and answer this, we looked at the methylation levels of the gene in the tumors, in normal tissue, and in the blood of both our patients who we found had an STHC epimutation and patients who we knew didn't have an epimutation. And we basically found no difference in the methylation level in the blood or normal tissue, suggesting that this fault is unique to a tumor and not something that we think can be passed on. So then that helps us in also trying to clarify what the screening should be. So for the patient who presents with the GIST or the paraganglioma and has an STHC epimutation, they need screening which should be similar to that of somebody with a germline STH mutation to screen for other tumors. And we think that that screening protocol probably should be close to what we recommend for patients with germline STHA mutations. But importantly, for the family members, they can be reassured. And right now, there's definitely not enough evidence to suggest that family members need to be worried, and they don't need screening. Okay, so then moving on to the STH preserved GIST then, and as I mentioned, the syndromic cause for this is neurofibromatosis type 1. Again, this gene is inherited in an autosomal dominant way, so again, a child of a patient who carries this gene will have a 50% risk of inheriting the gene. NF1 is a very heterogeneous condition, and typically the patients can be diagnosed clinically because they often have very specific features affecting their skin, such as patches of hypopigmentation, which we call café-au-lait spots. They can have these lumps in their skin called cutaneous neurofibromas, and they can have freckling in under their arms, which is very specific. These patients are also at risk of a range of tumors, including tumors affecting their optic nerve, nerve sheath tumors, other central nervous system tumors, neuroendocrine tumors, pheochromocytomas, and of course GIST. And to be honest, we weren't quite certain, and we still remain unsure as to how likely it is for a patient with NF1 to develop a GIST. Recently, there's been a study published from Finland where they retrospectively reviewed a register searching for a diagnosis of GIST, and they identified that over 1,410 patients had a diagnosis of GIST and NF1 in the time frame between 1987 and 2013. So that starts to give us a feel for how likely it is for these patients who have NF1 to develop a GIST, and I think we've probably been underdiagnosing it in clinical practice. The GISTs that develop in patients with NF1 are typically arising in the small bowel, and they can be multiple. And I would say if there is a patient in clinics that has a diagnosis of NF1, it's key for those patients to be followed up in a centre with expertise in NF1 at some point because of the range of other tumours and problems that can develop in these patients. Okay, so at this point, I'm going to hand back over to Dr. Bulusu for the remainder of the presentation, but I'll be available at the end for more questions.
Okay, thank you, Ruth. So basically, I think what we heard from Ruth is the fact that heterogeneity is the hallmark, and also we're still learning in the sense that we haven't come to a stage where we can confidently say that we understand every single bit about these rare subtypes of GIST. So right now in 2020, what is the standard of care for these patients who do not have activating mutations in KIT and PDGFR? You find a mutation or you find a driver and there is a drug available. The examples are BRAF and NTRK fusion GIST. So presently there are about two or three NTRK inhibitors available, and these have got agnostic license, meaning that irrespective of tumor site, they got a license as long as there are NTRK fusion abnormality. So what have we learned in the last 15, 20 years since we have had the 3 kinase inhibitors? One thing we learned with imatinib is both in STH deficient and also in NF1 GIST, imatinib does not seem to give any benefit. Having said that, if you talk to oncologists all over the world, across the world, there's always a case they have seen where there's a physical tumor shrinkage or the disease has remained stable for a number of months, maybe a number of years. It could be just the natural history of the disease. In our practice, we have not seen a physical shrinkage in a STH deficient GIST patient with imatinib. So tumor did not become smaller. In an NF1 patient, we had one patient who came to the national clinic where there was a response, a physical response. The tumor shrunk with imatinib for about 2 to 3 months, and then it grew back again. We're not sure what the mechanism is. Other thing what we have to remember with NF1 GIST is that sometimes NF1 patients may have a more common KIT mutated GIST. So you need to be careful before you say NF1 GIST responds to imatinib. So if you come down to second line, third line drugs, sunitinib and regorafenib, what we have seen in the clinic here and also the experience from the American and the European colleagues is that both sunitinib and regorafenib have some activity in SDH deficient GIST. It's more to do with perhaps the multi-targeted kinase inhibition rather than specifically to do with the KIT inhibition. And one concern we have with the sunitinib and regorafenib in the SDH deficient GIST is the long-term side effects. If you go back to the clinical trials in the KIT mutated GIST back to 2006, when sunitinib was licensed, the median time to progression was 27 weeks. That's about 7 months. And the GRID trial, George Dimitri's trial in 2012, the median progression time was about 4.8 months. So the amount of time the patients who are on these multi-targeted kinase inhibitors is roughly around 5-7 months. And in real life, we have had patients who are longer than a year, but very unlikely that will be longer than 1.5 to 2 years. Compare that with the SDH deficient GIST. Some of these patients have a relatively slow growing tumors and they can be on these drugs for a long time. So you need to be very, very careful before you introduce these drugs into this population, because we have seen some significant long-term side effects in the young patients with these multi-targeted kinase inhibitors. So need to be very careful about these things. So the situation is that we are stuck with 3 drugs which have very little or no activity, and we are in the process of understanding the biology of this tumor, so we're not there yet. So basically back to the drawing board and try and work out what is driving these tumors, how can we target, and that goes back to the biology. So if you go to NF1 tumors, and the one thing which has become very clear is what are the pathways which are involved in tumorigenesis, causing the tumors in NF1 patients with the NF1 mutations. 2 pathways stand out. One is the RAF-MEK pathway, and other is the PI3-P10 kinase pathways. So these are the 2 major pathways which are potentially druggable. And right now, there are kinase inhibitors which are RAF inhibitors and also MEK inhibitors. And also we got PI3 kinase inhibitors in clinical practice now, though they're not licensed for NF1 type of tumors, but there's a licensed FDA approval for a MEK inhibitor for NF1 plexiform neurofibroma. So potentially that would be a target. And whenever you have a new diagnosis or a new drug, you want to test out in clinical trials. And the only trial which so far has happened is in NIH. I'll come to that in a minute. Then we go back to our old friend succinase dehydrogenase deficient GIST. One thing I've learned is I had to go back to my school, medical school, secondary school biology. I had to learn very quick what this citric acid cycle or Krebs cycle is, and without understanding that, you wouldn't be able to understand what is happening with the succinate and the fumarate. So basically, the way I looked at it is that succinate has to be converted to fumarate, and that is done by the enzyme SDH. And SDH is not there, and succinate accumulates in the mitochondria. Normally, the succinate never leaves the mitochondria, never, ever. It doesn't go into the cytoplasm. So it is converted into fumarate and fumarate to other things, so that's how it works. So the succinate seeps into the cytoplasm and causes a lot of havoc in the cytoplasm and into the nucleus as well. So it triggers the downstream, the HIF alpha, which is one of the hypoxia-inducing factors, and causes some kind of a pseudo-hypoxic state. And also, same time, parallel to this, it also activates some of the hypermethylation in the tumors. And we also learned that there's also a problem with homologous repair of the DNA in patients who have succinate accumulation outside the mitochondria. potentially what you could ask is, if these are the mechanisms of oncogenesis or tumorigenesis, can these be targeted? So that would be the kind of holy grail when it comes to identifying a drug or intervention for patients with succinate dehydrogenase deficient yeast. One thing we have to remember is, what are the potential benefits we may achieve with an intervention, and what are the risks we're going to take? One phrase I use all the time, not just in gist, but all the time, is the one I've in my office, it's actually in big block letters, is primum non nocere. Primum means first, non means no, nocere means pain. So first, no pain, meaning don't harm the patient. So it doesn't matter what you do, if you think you're going to harm the patient, probably you shouldn't be doing it. And the second thing I remember is secundum succurrere. Succurrere means sugar. Secondum means second, means sweet, meaning help the patient. But the first rule, the primum non nocere, always trumps over the second rule. So you have to make sure that you're not actually physically or emotionally or psychologically harming the patient when you're intervening with any of the newer treatments. So this is something which is very, very important, especially in the rarer subtypes of yeast where the natural history may be quite indolent, and you want to be very careful before you subject the patient to any kind of a toxic treatment. So that thing is worth remembering. So how do we do? Where we go? One is clinical trials. Has to be biology based. No point in doing a basket trial for all comers. That's one thing we learned very quickly in GISTs, and more so in the wild type GIST. And I can't stress this enough. There's no point in doing single center, single investigator trials anymore. I think we have to stop people doing phase 1, phase 2 kind of early trials in a single center, waiting for about 10 years to recruit patients. And I beg and I plead to all my co-researchers and also to the patient advocates, please, 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 if you guys are doing or attempting to do phase 2 trials, single institute, talk to people, get into a dialogue with the other researchers where you can actually collaborate and do multinational trials. So that is a very, very key message for us, that actually when we're doing clinical trials, it has to be multi-center, multinational trials, and has to be driven by the patients and the patient advocates and the patient support groups. There's no point in actually one researcher or one guy who sits in a big regional or super regional cancer center trying to work out what his next step is going to be. The patients have to be involved, and they should be involved in driving the clinical trials. There's no doubt about that. And that should be the way forward in GIST. And we learned from other cancers as well. So we, apart from the systemic therapies we talked about, we also have some data coming through on the various local interventions we can do for GIST patients, especially for SDS deficient GIST patients. And we heard something about this. I think we had a talk yesterday about the non-systemic therapies. So surgical debulking, potentially an option, especially for either mass effect or pain relief. We have had 2, maybe 3 patients, I think we have done debulking in the post-GIST clinic where the reason was pain relief, and the surgical debulking has helped to cut down the amount of painkillers the patient was taking. We also done radiofrequency ablation for small tumors which are growing through, or sometimes that's the only tumor there. We don't want to really resect it. And we did RFA. Embolization is also an option. More recently, we embarked on this selective internal radiotherapy called SIRT, using yttrium, which is a radioisotope which can be injected locally through a catheter, which is put in the femoral artery, goes all the way to the common hepatic artery, and then we deliver the yttrium locally into the liver. So that we've been doing that for last about a year and a bit now. The only paper which has been presented so far is Peter Hohenberger's paper from Mannheim, where he presented an abstract in the ASCO this year. In the SDS deficient GIST, there's a median time to progression of 19 months, which is a very, very interesting data. And we are hoping to combine our data set with his data set so that we can get something out of this. interesting intervention. So going back to clinical trials, the one clinical trial which was presented in ASCO this year was the gordacitabine trial. Gordacitabine is a demethylating agent. As Ruth was saying, hypermethylation is the problem. And if we can actually get rid of the extra methyl groups, maybe perhaps we can actually make the gene function again. And that has been shown in a different disease called myelodysplasia, which is a kind of a bone marrow condition where there is a hypermethylation in the bone marrow stem cells. And the decitabine type of drugs have been used in that condition for a long time. So there is a hypothesis and there is a rationale for using this drug. So John Glodd, who is the chief investigator for the study, has presented the data in ASCO, and unfortunately they have not seen any signal. That means there was no response in this small group of patients. And there was a small number of SDS deficient just in this group, but they have not seen any signal. And we can ask a very provocative question: why did we not see a signal in this cohort of patients? And there are a lot of reasons for that. I won't go into details, but we can have a discussion at the end if we have time. This is another study with NF1, just again, NIH study, closed prematurely due to poor accrual. Basically, they didn't have any patients. I still feel that this should be pursued and should be a multinational effort, not single center effort. We could not share the protocol with NIH because of the regulations, regulatory restrictions. We had, while they were actually waiting on the patients, we actually had 3 patients who died with NF1 just in this country. So if we had a shared protocol in UK, in Europe, elsewhere, we could have finished this trial in no time and we could have had an answer instead of closing the study. So my big plea to everybody is collaborate and cooperate. Temozolomide is live now. Temozolomide is a chemotherapy drug used primarily in brain tumors. It is oral drug, and the trial is ongoing in the west coast of America. We have had some anecdotal reports of some efficacy. I've seen some imaging data which I can't share with you because they're not for public domain. But there is a physical objective response we have seen in this group of patients, but it looks like the responses are temporary. We don't have long-term data, but it seems to be that they respond for a while and tumors progress. So temozolomide on its own may not be the right drug or right single intervention. Maybe something should be added to this. Other concern we have with the temozolomide is the bone marrow toxicity. Though it is very well tolerated in the adult population, perhaps we may want to look at a different schedule for this drug. But again, that has to be done as part of a clinical trial. I talked about SIRT, S-I-R-T, selective internal radiotherapy. This is a patient of us who is 29, has a SDS deficient GIST. She had an epi mutation in the SDHC promoter gene, promoter component. So she had a gastric GIST which was taken out, and she had multiple liver metastases which have been slowly growing over a number of years. So she was diagnosed in 2016, and in 2019 we took her off all the medication. She stopped imatinib back in 2017 because she was getting a lot of toxicity, and we knew there was no benefit from it. So we treated our first patient in 2018. That patient had a very good response. So she's our second patient. She had yttrium labeled radioisotope, with the yttrium labeled beads injected into the liver. And she had a baseline MRI done in September 2019. And October 2019, she had the yttrium injection, the selective internal radiotherapy. And what you see on this here, you can see the blue arrows pointing towards the metastasis in the liver. And 9 months down the line, you can see they've shrunk, definitely have decreased in size. And also looking at the different phases of the MRI. The MRI guys tell me that they are less metabolically active. And we can actually try and confirm that by using some functional studies, but there is a definite physical shrinkage of the tumor. You can see that very clearly. And the both patients tolerate the treatment very well. They're transient radiation hepatitis. What I mean by that is temporarily they had a nausea and also the liver enzymes went up and they settled down within 2 to 4 weeks after completing the treatment. And the patient is now back fully functioning. So this is a very good example of using CERT, which was originally designed for colorectal cancer liver metastases. And this might be a tool which we can use in SDS deficiencies. So in summary, what do we have? One thing we have learned is heterogeneity. There's no doubt, though we use wild type, quadruple negative, quintuple negative, each individual patient is different. Each individual gist is different. And one thing which become very clear in the last 5 years since we run the clinic is we have to have that specialist multidisciplinary approach to this patient management. There's no doubt in my mind that you have to have that group of highly specialized people with expertise to make those decisions, both oncology, radiology, pathology, surgical, endocrinology, psychological support, specialist nurses, all these people coming together to help the patient. And as I said before, balancing the potential benefits of treatment versus side effects and maintaining the quality of life is very, very critical. We do not want to put the patients at risk of running into problems. And I can't stress this enough. Collaboration, collaboration, collaboration. It has to be very, very important. We need to understand that if we want to go forward in this rare cancer, we need to collaborate at the national and international level. And otherwise, we will be just sitting there 5 years down the line talking about the same things. And this is the key message, keeping the patients and the patient advocates at the center and right in the heart of this loop is the only driver for successful progress. I can't stress this enough because all of us researchers sitting here and actually looking at phase 1, phase 2 trials and all these things, there's no point in doing these things. We need to make sure that what the patients want, what the patient advocates want, and they should be designing and they should be driving us forward. And this is where I'm going to stop. Thank you very much indeed. It's been a fantastic pleasure to talk to you guys. Ruth and I were more than happy to take any questions.